If you'll just start by saying and spelling your first and last name.
Phillip Popovich, Phillip Popovich.
And how would you like to be titled?
I guess Dr. Popovich.
Okay. And you are with OSU Wexner Medical Center?
Yes.
Okay. So tell me about this research with mice. I boiled it down in my head, and you can tell me if I'm right or wrong, but basically this widely used pain medication has been found to be effective in mice at not only managing symptoms that come from spinal cord injuries, but maybe stopping the ripple effects in their tracks. Is that correct?
Yes and no. I think that maybe the easiest way to explain it is that the drug that we tested is a drug that's used very, very often in people. In fact, it's one of the most widely prescribed drug medications in people in general. It's widely used to treat neuropathic pain. Okay, so if you've ever had any type of pain syndromes, gabapentin is a drug that you may have been prescribed by your doctor. In people with spinal cord injuries, it is often used to treat neuropathic pain because that's a complication that usually develops after a spinal cord injury. But typically you don't get the drug until you get the pain, right? So it typically is months or sometimes even years after the onset, after you suffer the spinal cord injury, that you're prescribed the drug. What we know now that we didn't know when gabapentin was first developed as a drug is where it acts on cells, the molecular target, if you will. And what we've just, our lab didn't discover this, but others have shown that this drug, gabapentin, binds to a specific protein found on neurons. Okay, so these are the cells that can make the electrical communications within your brain and spinal cord that help you move, think, walk, etc. When gabapentin binds to this protein, it is effective in slowing the neurotransmission or the communication between the nerves that ends up causing the pain. It also, we've now understand, when it binds to this protein, it also keeps synapses from forming. So what are synapses? Synapses are essentially little molecular handshakes between neurons. Neurons talk to one another through synapses. And when gabapentin is bound to this protein on these neurons, it keeps new synapses from forming. So after spinal cord injury, one of the reasons that pain develops and a lot of other secondary complications develop that involve what's called the autonomic nervous system, so cardiovascular problems, immunological problems. Part of the reason those problems develop is because in the spinal cord, these synapses increase in number and they form new pathways to communicate, right? And those new pathways are abnormal pathways. So they're creating this circuitous communication network that leads to problems, okay? Harmful problems. What gabapentin does is if we can get it in there early, okay, before these proteins come up to cause these new connections to form, we can block them. And so that's what we found in the mice, is that if we take gabapentin, don't treat animals after they've developed symptoms, but start them early because we know they are going to develop them. If we get the gabapentin in there early, we block these bad, harmful neural connections from happening. And we're able to at least reverse cardiovascular dysfunction, or not reverse it, but actually keep it from happening, keep it from developing. And we also are able to block the immunological deficits or suppression of the immune system that happens in spinal injured animals. So these same things happen in people. Cardiovascular dysfunction, immunological dysfunction, pain, all these things happen in people with spinal cord injury. Same thing happens in our mouse models. So we are basically proposing now that here's a drug that exists in the clinic. It's given to people widely, it's safe, it's used all the time, but it's usually given after the fact. So when symptom onset starts, we're saying if you have a high level injury and you have a serious, severe spinal cord injury and you are at risk to develop these problems, why not give gabapentin early and block them, keep them from happening? It may be that we're able to prevent all these secondary consequences of spinal cord injury from happening in people.
Is this considered groundbreaking, and what does this mean for patients?
Well, I mean, I don't know that it's going to be considered as groundbreaking. I think it's a significant change in perspective on a long-standing medical treatment. So if you asked any clinician who prescribes gabapentin, what do you think about the idea of using it in a different way to prevent, as a preventative drug rather than as a treatment? They would think that is I would think that they would think that's a paradigm shift. It's a new way of using the drug in a way that could significantly change how people are treated and how they respond to their spinal cord injuries.
Why is this so important? Why is this so needed?
So people with injuries, spinal cord injuries, the complications that they suffer as a secondary consequence, most of the time, if you see somebody in a wheelchair, you think, oh, they can't walk. They're paralyzed. And that's true. But that is usually not one of the bigger problems that those individuals are suffering from. They have a lot of other complications that are more silent to you and I, but to them are the things that cause them to become rehospitalized or that cause them to die prematurely. So things like secondary infections as a result of immunological dysfunction or immune suppression, autonomic dysreflexia or an abnormal cardiovascular reflex, which involves very high blood pressure changes that are unregulated. Those things can lead to hospitalization. They can also cause a variety of other problems that can kill the patients. So keeping that circuit from forming, keeping those neurons from causing those harmful changes can keep people alive, keep them out of the hospital, and give them a much greater quality of life.
And just to clarify, what part of the research was conducted at OSU, if any part of the research?
All of the research was done at OSU. We had some collaborators on there who provided reagents or analytical skills, but all of the research was done here.
What's the timeline? How soon? What happens next?
Well, I think what happens next is, so gabapentin, like any drug, has the ability to influence other cell types, and it can have off-target effects, it can have side effects. And so I think that one of the things that we're working on right now is to try to figure out how long after the injury can we wait to start the drug and still have the effect, because there is what we would call a critical window during which time treatment or preventative treatment with gabapentin is going to be effective. If we wait too long, those harmful connections may form, and then we can't block them anymore with gabapentin. So we're still trying to figure out what that treatment window is. Then translating that into people will be the next step. What is going to be an equivalent time window post-injury? Because time window in mice may not be the same as humans. In fact, it's unlikely to be the same in humans. A mouse lives about 2 years, right? And so they have a very accelerated time window, which means, if we're safe in giving animals drugs within 3 to 7 days, that may equate to 4 to 6 weeks in people. So it's hard to know that without actually testing it. So my hope is that once we can work out a little bit more and understand how the drug influences cells outside the nervous system, maybe in your bone, your liver, because there is some evidence that the drug will affect those organs. If we can prove that it's not causing any abnormal effects, or we can understand how it's affecting those organs so that we can manage that during treatment, then we can go to the clinic and say to doctors, okay, you should be dosing people with drug early, but you need to monitor organ A, B, and C to make sure that those stay functional as well. And hopefully what we can do is to find a critical period of time where we can dose people, then take them off the drug, and still maintain the protection. So there's still a little bit of what we would call preclinical work in the mice before we're able to say, all right, here's a guideline that you should test in humans. And then I would guess that it's going to be dependent upon individual clinics, how they want to try it and how they want to test it. Since it's already an FDA-approved drug, they would be safe to prescribe it. And it would be up to them to prescribe on a case-by-case basis and test it within their institution about how they would like to administer the drug. My hope is that we get multi-center studies where we get spinal cord injury clinics across the United States would be a great place to start, where they test X number of patients with gabapentin in the acute post-injury period, and we monitor various outcome measures over time to see if we have benefit. There is some evidence in humans already, the retrospective case studies, where they've gone in and they've evaluated data long after the patients were in the hospital, and found out that patients who were given gabapentin within the first month after their injury, for whatever reason, ended up having better outcomes in terms of motor function. So those data actually help prompt us a little bit to think, you know, early could be better, but why is it better? Our study actually shows and gives definitive proof in an animal model that early actually modifies how the spinal cord itself responds to the injury.
So fascinating. One last thing, how common are spinal cord injuries? Is there a statistic on that?
Yeah, there's statistics, but none of them are good. They're all over the place. I hesitate to even give you numbers because there's so many different statistical models. It's considered a rare disorder. It's not a common neurological problem, but it's a incredibly expensive problem, and part of the reason. So if you were to compare the cost of management from a clinical perspective and then from a hospital discharge and family perspective, the societal impact and the cost impact of spinal cord injuries rivals some of the most expensive cardiovascular diseases, et cetera. And it's because people who get spinal cord injuries are typically very young, and then they live 40, 50, 60 years needing constant medical care, needing assistive devices, and it's not just the individual who's affected, it's also the family and the caregivers who also need to make sure they maintain. And the more severe the injury, the more expensive and the harder it is to manage.
Dr. Popovich, thank you